We're here on a special program with Warren Ninjas, who has actually done 2 other programs on antivirals and also on PrEP, which is pre-exposure prophylaxis for HIV infection. In discussing that, we also had in sections of that some touch on travel medicine, which is really important for anyone, no matter who you are. The chance of you coming in contact with some pathogen or biologic on a trip is pretty important to be concerned about. So you have a travel clinic. You have the Seattle Infectious Disease Clinic, and you also have the Seattle Travel Preventative Medicine Clinic.
Yes.
Both of which are, one is more of a natural flow thing with the money, and the other one's more of a cash up front program, but both of them are really important. So I want to have you, thank you for being here and doing all of this. Tell us about travel medicine. This is important to consider before you travel.
Right, particularly when you're going to the developing world. In essence, travel medicine is a way to take healthy people and have them go on wonderful trips and remain healthy on those trips and return home. And they need basically to be evaluated before they travel to look at what are the risks of where they're going, what are their unique risks in terms of their own immune deficiencies or compromise, and then what interventions they should have to stay healthy before, during, and after their trip. And that's really what travel medicine is as a patient comes for a pre-travel visit with me, and I sit down and talk with them about specific risks and then how to intervene to prevent or lower those risks. And then also, rarely when people come back and are sick, I see them as a sick travel visit once they've returned from travel.
I have one of our previous co-workers went on, I guess it's the extended governmental program where they send them into a country and allow them to help the country and so forth, all in good stead. But she had gone through a rigorous process, and I don't know if you're ever a part of that, where there's people who actually have to go through the process for the government to make sure that they're not going to be having anything going in, and that they're assured that whatever it is they got over there was really gotten over there.
Right.
So
we see quite a few travelers from the Gates Foundation. There's several other basically not-for-profit organizations in Seattle that send quite a few people into Africa, into Asia, and across the globe for public health interest, and we end up seeing a lot of them before they go on those same trips.
When you have a person who is, I don't know, they might already be involved with this organization, and when there's an emergency, then they have to take off pretty doggone quick. How are you involved with any of that, or do they have a special route that they go through to get all the inoculations and whatever it is?
It varies. Some companies have their own in-house clinics, but most companies actually have their employees just go to their primary care doctor or to come find their own travel clinic. And we do see a lot of just travelers who find us on the internet and come in, and they're going to go to a wonderful safari in Africa, and they want to know how to stay safe when they're there. Or they're going down to Costa Rica for a vacation, or going through the Panama Canal, or I've had patients on cruise ships where they're going to hit 7 different ports. And each of those ports have different risks that we have to go over. So it's enormously varied person to person, what sort of health the person is in to start off with, and then what interventions they need to have to keep them safe.
Because they can't just say, okay, I'm not going to get off the ship in this port, because they'll still be with all the other people on the ship that have maybe gotten it secondhand, and now they'll get it again, from another direction.
Right.
But
and like for cruise ships alone, they're a risk factor for norovirus and other diarrheal spread of disease. So I inform patients who are on cruises about norovirus-associated illness and other basically travel diarrhea syndromes that are associated with being in a densely packed vessel. So all important steps we go over with the patient and look at their own specific risks, along with a list of several things that we just discuss almost all the time with all of the patients. So one of the biggest issues, and actually the highest risk disease when you're going to the developing world, is traveler's diarrhea. Acute diarrheal illness in the US is usually caused by viruses, so we don't usually treat it with antibiotics. While when you go to the developing world, there's a particular E. coli that causes most of traveler's diarrhea, as well as other organisms, and there's more likely than not that the abrupt onset of diarrhea is due to bacteria. So we actually do prophylax patients to prevent travelers' diarrhea when they go to the developing world. You can either give them medicine they take all the time, like rifaximin or Pepto-Bismol, or you give them medicine that they take when they develop diarrheal syndrome. And they're acute antibiotics, and we tailor which one based on the particular patient and which part of the world they're going to. But in essence, it's an acute, in-the-pocket approach to treating travelers' diarrhea should they develop it. We talk to them about food safety, how to eat safe foods when you travel. And we say to boil it, cook it, or peel it. So everything thoroughly cooked, thoroughly boiled, or thick-skinned fruits and vegetables that you peel. We also talk about not using ice, because you don't know if the ice has been made with clean water or not. Don't drink shower water when you're in the shower. Very important. Also, we talk about you don't want food that's been kept warm at long periods of time. That is even true in the United States. If you eat at a buffet, though the food's been out there more than 2 hours, you start to run risk of basically becoming ill. So that's very important. Also, food that's been prepped by street vendors and kept warm for long periods of time, you don't want that. You want your food immediately cooked and prepped, taken to full cooking temperature, and then immediately served and you consume it. That's how you have safe food when you travel. We also talk with patients then about how they manage their diarrheal illness should they get it. What are markers for how they have effectively treated it versus when they might need to go seek further health care if it's not being treated well. There's also diseases. A big part that we look at are vaccine preventable diseases. There are many different travel vaccines. Some of them, it's just a time to update the regular vaccines, such as seasonal influenza or tetanus, diphtheria, and pertussis. If you're going to be flying somewhere, you're going to be within coughing distance of 16 people you can't get away from on the airplane, both going and coming. Many of my travelers will survive the flu. They're otherwise healthy young people. But you don't want to start a 1 or 2 week vacation with the flu. So I definitely recommend flu shots before all travel. And we also look at tetanus and diphtheria and pertussis. And then most younger people have already received hepatitis A and sometimes hepatitis B vaccine, but those are important for travelers. Typhoid vaccination is another bacterial disease caused by contaminated food, and I definitely recommend typhoid vaccination for all travelers to the developing world. Hepatitis B is a little bit more variable. Its mode of transmission is either sex or blood, and so most travelers are at risk for if they need a blood transfusion due to, say, a motor vehicle accident or some other accident where they need a blood transfusion. Most are not at risk for sexual transmission, although we do have travelers that have sex when they travel, and that's another issue to discuss is condom use and to be safe when they're traveling if that might be an issue.
Are people more or less in other countries, the countries that we'd be going to from a country that doesn't have this prevalence of this particular pathogen, when you are exposed to that pathogen in another country, are those people in the other country immune to that pathogen, or are they just have innate immunity to it, to the acute infection? Or?
Yeah, it varies enormously based on which infection. So if you look at sub-Saharan Africa and malaria, the population has actually been adjusted based on its genetics with its interaction with the malaria parasite. So many people in Africa have immunity to malaria since they were a very young child. And so those people...
Their immune system has seen it and done whatever it's going to do to prevent it from actually becoming an acute infection. It's a chronic, mild, not in...
or even it can be subacute where they will get it occasionally, several times in their life.
But it's tolerable because it's
right.
not... But we might see a different course of disease.
Right. So definitely people who are, say, from Washington State who travel to sub-Saharan Africa are at enormous risk of falciparum malaria in certain regions. It's a very bad disease, and 1 million people per year die from malaria. So when I talk with my travelers, I want them to be protected from malaria. And it's very straightforward. There's very good medicines to prevent malaria transmission. We also use insect repellent, and that prevents other transmitted diseases through biting insects. And we also recommend use of mosquito nets with repellent in them if they're going to be staying outdoors in a non-screened-in area. Something we discuss with them. Also, I mentioned there are some other vaccines that are very specific to travel. Yellow fever vaccine if you're going to the Amazon, and also yellow fever if you're going to areas within sub-Saharan Africa. Polio vaccine, we've almost eradicated polio in the world, but there are still some places that have polio where they've either found it within samples of stool that they've tested, like recently in Israel, or they've had it in other countries, like there was recently some in Syria. And several years ago, there were some imported cases in China. And I use as a threshold whether or not someone needs a polio vaccine as to whether or not there's been a case of polio in that country in the last 2 years. And the last real travel just associated vaccine is meningococcal vaccination. There's a meningitis belt across Africa, and you really need meningitis vaccine to travel there, as well as also if you're going to Saudi Arabia during the Hajj, it's required to have meningococcal vaccination.
Do you address, how do you address the issue possibly around C. difficile?
Yeah, that is typically, there's some community-acquired C. difficile associated infections in the U.S., but in general, this used to be mostly a healthcare-associated infection. And the same was true for MRSA. We used to only really see methicillin-resistant Staph aureus in hospitals, and now we see more community-acquired MRSA infection to the point that when we're treating something that might be Staph aureus infection, we have to cover it for MRSA. The same is true now for C. difficile. We're seeing much more community-acquired C. diff. I haven't seen that in travelers as much. I've not yet had a traveler come back with diarrheal illness that needed C. diff treatment. We normally, the antibiotics we use to treat travelers' diarrhea would not cover C. diff. So really it would be a returning traveler who didn't have a good response to the usual therapy that then we do further stool studies to find out if they had C. diff.
And how about TB and MDR TB and XTR TB?
Well, certainly tuberculosis in general, we have a different approach to it in the U.S. than a lot of the rest of the world, where they vaccinate against tuberculosis using a vaccine called the BCG vaccine. In the U.S., we use active surveillance and case finding to control tuberculosis. So people at risk, we test them for TB, like healthcare workers, we test annually, either through a blood test or a skin test, and if they turn positive. When travelers go to places at high incidence of TB, I do recommend that they get tested for tuberculosis once they return. But it can take weeks to months before those tests turn positive. So really, latent TB, which is what most people get whenever they end up initially becoming colonized with tuberculosis, won't clinically present for quite a while. And we won't have the tools to test people for at least several weeks to months since they return. We also people should make a list of any medications they're taking, and they should take them, particularly if they're a controlled substance, in the container that they've been prescribed in, not in laid out pill boxes. That's very important when you're looking at opiates.
And will most of the traveling public have an issue at border crossings with just a pill bottle, or do you have to have a prescription per se?
Most people will have no problem at all. But if you show up with a large pill bottle of a 90-day supply of your OxyContin prescription, you could end up having some problems. So I definitely, if it's a controlled substance where you have to have a written prescription to get it from the doctor.
You might not want to travel.
Definitely be careful. And there's even one country that Benadryl is a controlled substance because it can be diverted to recreational drug supply.
Right, that's true. Yeah.
So you have to be careful even in those other countries that you wouldn't expect for medicines that are not controlled in the U.S. And then also there's something called the Smart Traveler Program. It's put on by the State Department, and you can go to the website there, and what it allows you to do is to register your passport, let them know when you're going to be in country, give them contact information so they can get a hold of you if they need to. They also send you travel updates. It's at no cost for travelers.
If something comes up and you just don't see it in the news because you're in a foreign country with foreign news,
correct,
you might want to have that. That's a great, I never thought about that, and that's a great feature.
Many travelers are not aware of the program. It's at no cost to American taxpayers. You register, they basically can get your cell phone contact information, your email contact information, and also your family contacts. They'll let you know when you're going to be in country. And if also, people don't realize that there's a network of embassies and consulates across the world that you can call for assistance. And if you need a doctor, clinic, or hospital, you call your local embassy or consulate and ask them who they send their patients to, their basically staff there to. They send them to a local doctor, and it's generally someone you know is going to be relatively safe compared to trying to find a doctor in a foreign language, foreign land with no clue of how their healthcare system works.
You know, this has been very, very helpful. I think your covering some really important topics, and I think well thought out. Obviously, you do a good job with the work. How long does it take to go through a patient's history or preliminary workup and then get out the door?
It varies enormously based on where people are going. So if someone's only going to, say, a mostly first world country like Japan, where the risk may be only new Japanese encephalitis and we need to update their flu shot and Tdap, it can be a 15-minute visit. If they're going to several countries on a cruise through Southern America, it can be long, and with multiple countries in Africa, and each of the risks vary through there, and it matters what order they go to the different countries. And so it can be anywhere from usually 20 minutes to 45 minutes or an hour for a single visit. We also do group visits where if a couple is going, I'll see them both at the same time. And we give discount rates for group visits. And usually it ends up being the actual physician charge for my time is not that expensive. As it turns out, vaccines, and particularly travel vaccines, are very expensive. And they're not covered by insurance, which is exactly why I had to carve that out of my practice. Is if someone comes and with regular Humana, Cigna, Regents, most health insurance will not cover that travel cost vaccination.
How do you work this out with the? I mean, do you ever do a group, like say a whole church is going somewhere?
I haven't yet. There are some local schools that have frequent trips to specific locations where they rotate. I can think of one school that every other year they send people to Vietnam, and we end up seeing in our travel clinic quite a few of those kids and their families who are going over there either as chaperones or the kids themselves going to the same location. So very commonly we'll see large numbers of people going to the same place, but my office is a typical physician office. You can only usually fit about 2, 3, 4 people in a room. It gets kind of tight when we have 4 or 5 people in there. So we usually limit it to those 4 or 5 people. And then if there needed to be larger groups, we could certainly address that, but I haven't had that yet approached, or haven't been approached by that.
I travel after half of the last dozen years every summer somewhere in the Southern Hemisphere, and it seems as though this is something I never give it a chance with the flu vaccine, because you just mentioned you have to update your, obviously the immunity is just for this particular version of it, and this year isn't very good anyway, through March and or so, and then if I was going in July, I would have to get the version of that, what they suppose based upon this last year in our country probably, what that new vaccine is, whatever it is, they would then, where would you get that? Because it's really only going to be produced for the people in that Southern Hemisphere, or is there, do they make it available here too?
I mean, most flu vaccines in the US, they're only the versions that are circulating here. You couldn't get a different version that they use in Brazil here in the US. And the same is true for like Japanese encephalitis, for all of southern Eastern Asia and northern Australia, northeastern Australia, the corner. Basically, that vaccine is extremely expensive. It's around $300 in the US, and it requires a 2-dose series. Yet, if you go to those countries to get it, it's actually quite inexpensive.
But if I'm going to go to that country,
you won't
and
have
I'm only
immunity.
there for 2 weeks,
Right. Well, and that,
I'll be good in about the time I get back.
That particular vaccine is really only recommended if you're going to be spending 4 weeks in a rural area. So I do have people who are going to say be taking a biking trip across down the entire Vietnam coast. And for those patients, I consider that they're not at enormous risk if they're staying mostly in cities, but they do have some risk when they're getting in rural areas. And in those cases, I suggest to save money that they get the vaccine when they arrive. And there's usually health clinics associated with most airports. You can go in and start your 2-shot series when you're there. The risk of the first 2 weeks, if you're going to be there for 3 months, is not relatively high.
It's a different story than a 2-week traveler or business traveler or whatever.
Correct, definitely. And then some of the last issues, people don't realize sun exposure. Very important, leads to sun cancers later in life. And you should have basically sun repellent or sunblock on, and use that liberally when you're sitting on the beach or by the cabana. And then lastly, immune compromised or pregnant travelers. I generally recommend anyone who has significant immune compromise, either through HIV or AIDS, cancer, or some rheumatologic agents. We're giving quite a bit of these to patients now, like Remicade or for rheumatoid arthritis or other autoimmune diseases. They should really seek out the consultation of a travel expert, because how you manage that patient going to the developing world is very different. And then also, when people have left the developing world and have come to the US to live, those travelers returning back to their countries don't necessarily have the same risk profile of going, we call them basically visiting friends and relatives. Mm-hmm. And so someone who grew up in Africa who had immunity to malaria, if they leave and they've been in the United States for 20 years, they now, when they go back, are no longer significantly immune from malaria, and they're at higher risk of having problems from malaria. So in that case, those people, we would put them on malaria medication, while if it were someone who was there in Africa, they're obviously not on malaria medication when they're moving around there. So there's a lot of differences in unique tailoring of the healthcare for people based on the location and their own existing health issues.
Mm-hmm. Well, Warren, this has been really great, and I so much appreciate this extended segment that we started out to make it a 5-minute. It's probably worked into about 30 minutes. But it really is important that we had this in there. And you obviously know what you're doing in this clinic. And I think having someone like you, hopefully there's people like that in other areas. But since this goes up on the internet, people can look for a travel medicine doctor or network to find one in their area, even if it's the health department, to get addressing the issues that they're going to face when they travel.
Yeah. And there are many areas where it's only a public health department that has the available vaccines. Mm-hmm. But like we are a yellow fever vaccine clinic, and you have to specifically be registered as a yellow fever vaccine clinic in basically every state in this country. So
probably one of the bigger ones that you have to be concerned about, I guess, at this point.
Yes, definitely for Amazon travel and sub-Saharan African travel.
Thank you so much.
You're welcome.
Appreciate it.